Tele-oncology at Huntsman Cancer Institute and the University of Utah is a fairly new endeavor. We have an outreach clinic in western Wyoming in Jackson Hole, where we serve a greater part of western Wyoming, but it's very hard to get up there on a regular basis, and it gives us the ability, in addition to our regular visits, to deal with patients on an acute basis if new problems arise or new challenges develop, so that we can deal with them in a fairly quick and intimate fashion, the same as if we were there. A recent patient showed up with a new liver mass. We're not going to be up there for a couple of weeks. We were able to review the imaging, talk to her and her family on the phone, and arrange for her to be seen at our hospital for the appropriate surgery without delay. Our first few experiences with this have been very positive, as reported by the patients who participated. I think that we wait to see how it develops, but based on data from elsewhere, we expect it to go well. I think tele-oncology could well save patients money in the sense that we may be able to reduce travel time. Certainly, although maybe not necessarily money saving, it will be anxiety saving.
Telepsychiatry here at the University of Utah has been going on for probably 4 to 5 years, but it's really starting to expand over the last year or two. It used to be we'd have to drive to small towns, far away, spend a lot of our time. But now we can telecommute, if you will, to several hundred miles by walking into the telepsychiatry office we have, and work with patients in southeastern Utah, northeastern Utah, and anywhere in between. It's been so successful that we've actually created small programs to actually take advantage of modern day electronic communication, and we've developed programs to help the primary care provider have rapid access to our expertise as child psychiatrists. And this has been, so far, been very well received by pediatricians and the families, because we're able to help them with their difficult patients, yet they keep control of the patient, keeps the family happy, they stay at home, and we feel like people are getting good care faster, which we think will overall help everyone and keep quality high and costs down.
Our teleburn program at University of Utah Healthcare started in 2004 when we received a federal grant to help support the initiation of teleburn services locally that tied us into 3 of our major providers in the surrounding states who frequently refer burn patients to us. Since that time, our program has consistently grown. We still use it for outpatient burns that we strictly see on an emergent basis as an emergency consultation. In addition, we also now have a setup with the St. Alphonsus Hospital in Boise, where we work with them to deliver ongoing care to our patients from the Boise and the southwestern Idaho area. This has been a tremendous service both to the care providers in the region, because it's very easy for them to get a timely and immediate feedback from us in terms of a patient with burn or a similar injury. It's also been very nice for our patients and their families. We have a lot of patients up in Idaho who I've never met in person, but who I've done consistent telemedicine follow-up with over the course of months to years now.
So University of Utah Healthcare started its telestroke program about 2004, and we've grown quite a bit since then. We now have 12 sites in state and another three sites out of state in 3 separate states. And we've been really proud of our program because it enables us to evaluate patients with possible stroke, even in remote communities that don't have a neurologist, or even community hospitals that are in the city but don't have enough neurologists. And we're able to tell whether they're having a stroke by doing a direct face-to-face interview and physical exam, and then recommending the best treatment based on what we see over the camera. We can also determine whether they need to be transported to us, or sometimes they don't need to be transported to us because they're not actually suffering from a stroke. And so we're able to save community hospitals from transferring patients that they could care for in their local facility. So we've been delighted with the program in the sense that we feel that we're providing great care to our surrounding communities and extending the expertise that we have here at the university to those areas. In addition, we follow our quality outcomes, and they've been excellent, on par with those patients that we treat here in the university within our own emergency department.
The University of Utah, one of my primary clinical areas is wound healing and surgery for flaps. With the telesurgery component of the telemedicine process, we can consult with doctors, and so far it's mainly been done in the Boise area. Paraplegics and quadriplegics who are confined to bed commonly develop wounds on their lower back side. It's difficult to transfer those patients, so we can do our preoperative evaluation and the majority of our postoperative care through telemedicine. The patients do come down here for surgery after we evaluate them. With telemedicine, we can get a very good look at their wound. The doctor is usually present, so we can get their full medical history and any pertinent lab values. And then we arrange for transfer. The patients come here, have surgery, usually stay a week out of a 4-week recovery period, and then can go back home, be closer to their family, and have the last 3 weeks of their care done with their local physician, but we can keep track of them through the telemedicine process. It saves certainly a preoperative visit and usually a postoperative visit. It's been great for us, and I think very good for the patients.